Welcome to Legend Information.
You may perform range of motion on the digits one joint at a time or in combination. Achieving range of motion of the multi-joint extrinsic muscles requires moving the fingers and wrist simultaneously, first into flexion, then into extension. As you progress from passive to active assistive range of motion, maintain the same hand placement so you can provide support and guidance for any segment of the range the muscles are not strong enough to control. With shoulder flexion extension, the patient will need assistance when initiating the range and when completing the range where gravity has the greatest resistive effect. When performing elbow and forearm range of motion, start by flexing and extending the elbow with the forearm supinated. And then with the forearm pronated. Isolate forearm pronation and supination with the elbow positioned in flexion and in extension. When the elbow is in extension, stabilize the humerus to prevent the shoulder from rotating. Ranges for hip and knee into flexion-extension are combined. Support the knee so it does not drop into extension as the leg is lowered. Abduction is performed with the hip neutral to rotation. Hip rotation may be performed with the hip extended or with the hip at 90 degrees. When rotating the hip in the 90-90 position, support the knee with one hand. Apply resistance at the level of the metacarpals to the four primary wrist motions: flexion, extension, radial deviation, and ulnar deviation. Do not restrict finger motion. Apply resistance to individual wrist muscles by aligning the resistive force with the tendon attachment, as demonstrated here with the flexor carpi ulnaris. Position the elbow in 90 degrees flexion and apply resistance to the radius at the distal forearm. For patient comfort, apply resistance with the palm of your hand. Do not apply resistance to the palm of the patient's hand, as it might stress the wrist joint structures. Each joint in the fingers and thumb can be isolated to strengthen specific muscles or actions, such as proximal interphalangeal joint flexion or thumb opposition. Stabilize the proximal bone and apply resistance distal to the moving joint. For general strengthening, resistance can be applied to several joints simultaneously. When resisting knee flexion and extension, the position of the hip affects tension placed on the two-joint hamstring and rectus femoris muscles, so the range may be limited. In a prone position, flexing the knee stretches the rectus femoris. In a sitting position, extending the knee stretches the hamstrings. The position should be modified depending on the patient's flexibility. All motions of the hip can be manually resisted with the patient in the supine position. For full range of hip flexion, the knee must flex to take tension off the two-joint hamstrings. It is possible to resist hip and knee flexion simultaneously, and then hip and knee extension simultaneously. Resist internal and external rotation with the hip flexed and knee flexed with pressure against the leg. Be sure the knee is stable. Hip rotation can also be resisted with the hip and knee extended. Resistance is applied to ankle dorsiflexion by resisting along the dorsum of the foot. And applied to ankle plantar flexion by resisting along the plantar aspect of the foot. Individual muscles can be isolated by aligning the resistance with the line of pull of the tendons, such as the anterior tibialis. Resistance to inversion is applied along the medial border of the foot and resistance to eversion is applied along the lateral border. Resistance to the toe musculature should be applied to all the toes simultaneously. It is difficult for most people to isolate toe motions. For elbow flexion, manual resistance may be applied with the patient supine, sitting, or prone. Stabilize the anterior shoulder and apply resistance to the distal end of the patient's forearm with the forearm supinated to emphasize the biceps brachii. In mid-position to emphasize the brachioradialis, and pronated to emphasize the brachialis muscles. Resistance to the triceps brachii is not affected by the forearm's position. The patient may be supine, prone, sitting, or lying on his or her side. During scapular elevation, apply resistance along the superior aspect of the shoulder girdle. During depression, apply resistance below the inferior angle of the scapula or have the patient press the arm downward into your hand. Resist protraction at the anterior portion of the shoulder and resist retraction along the medial border of the scapula. With the patient sitting, apply bilateral resistance to scapular elevation. In order to flex the pelvis on the lumbar spine, flex the hips and knees of both lower extremities and bring the knees toward the patient's chest. If the patient is very flexible, you may have to reach under the pelvis and lift the pelvis upward. Good body mechanics is essential. For rotation of the spine, begin with the patient in the hook-lying position. After stabilizing the thorax with a hand on the opposite shoulder, push the knees laterally in one direction until the pelvis on the opposite side comes up off the table. For range of motion exercises, the patient should wear loose clothing, with draping added to preserve the patient's modesty. Place your hands so they provide good support for the patient's joints and allow smooth movement through the available range of motion. Perform several repetitions of flexion-extension. Transition to abduction-adduction. Then internal and external rotation, and conclude with horizontal abduction-adduction. When performing range of motion for the wrist, make sure the fingers are free to move so the extrinsic muscles do not restrict motion at the wrist. Cupping and flattening the arch of the hand is important to maintain mobility for gripping and releasing activities. For ankle and foot range of motion, first cup the heel with one hand and move the foot into dorsiflexion by pulling distally with your fingers and hand while moving the rest of the foot cranially with your forearm along the bottom of the foot. Then perform inversion and eversion by turning the calcaneus inward and outward. Supination and pronation are complex motions involving all of the joints of the foot. Therefore, grasp around the metatarsals and turn the forefoot inward while raising the arch and outward while lowering the arch. Make sure you include range of motion to the joints of the toes.